Hi everyone, welcome to North of 60. My guest today is Laura Kelly. Laura is a licensed social worker with a master's in social work and works as the coordinator of bereavement and social services at the Gardens of Western Reserve Hospice. That's a lot to say. How'd you get started in hospice, Laura?
Well, I was doing individual and family therapy before I had made the transition.
Oh.
And so when I was on maternity leave with my firstborn, I was looking at different avenues, and I just wanted to kind of lean into discomfort because death has always kind of been an uncomfortable topic for me personally. So I just wanted to explore that further, and that's kind of how I chose that route.
How interesting. And you've been there for 4 years now?
Yes. Mm-hmm.
So you must like what you're doing.
Oh, I love it. I feel like it's a calling. So
I have heard that exact phrase from other people who work in hospice.
yeah.
There must be something about the clients, the teamwork. Something happens to all of you wonderful people who can do that.
Yeah, it really is. It's a blessing to be able to help our patients and our families during such a vulnerable time.
Sure.
So
You have two roles, social work and bereavement. Let's
Yes.
talk about the social worker role
Okay.
first. So what do you do and how do you get involved with the family in the first place?
okay, so when someone first comes on our services, the social worker has 5 days to do what's called an initial psychosocial assessment. So we reach out to the family and we identify their needs. And so it could be anywhere. They might have financial needs, or if they're in the home, maybe they need some help with getting connected to some private care duties, things of that nature. Identifying what their emotional needs are and going from there. So,
Quick question. So they have contacted Gardens of Western Reserve Hospice to say, I want your services, and then you are the first person to see them.
well, it could be a variety. So to be on hospice services, first it would come from a doctor's order to
Okay.
to determine that individual is hospice appropriate. And then we would have a nurse go out and evaluate.
Okay.
Yeah, so then once they're determined to be appropriate for hospice, then our nurses would go out and do an initial nursing assessment and things like that. So myself, the social worker, and our chaplain, we're additional supports for the family. So,
Okay. So then the nurse would say to the family, would you like to see a social worker, or would simply give you a referral,
Yes.
and you would go and visit with the family and
Right.
determine. Do you do education?
We do. So the education, it varies. So a lot of times we help connect people with legal things like a power of attorney paperwork or a living will. Sometimes we're like the layman, like the middleman, to explain some of the nursing terms into everyday terms that sometimes make it a little easier to comprehend because it's a lot. And a lot of it too is just when you go on hospice, you're shifting your philosophy from treating to cure to treating for comfort. So there's a lot of change with that and a lot
Sure.
of adjusting in different ways. So, that's definitely the role of the chaplain and myself to kind of help that transition.
That must be difficult. That must be difficult because my parents both had hospice services towards the end of their lives. And I remember for our entire family, at times we kept thinking, well, mom should see the doctor, or something's wrong, we need to go see the doctor, or bring,
Right.
when in fact, I think it was us and her having difficulty making that you're going to be okay, we're going to make sure you're comfortable, but we're not going to treat this anymore.
Right. So, and that I think is very common, especially with patients that maybe have a terminal cancer diagnosis. They want to see where they're at with the cancer progression, and a lot of times, Medicare won't cover certain visits when you're on hospice, and so, it's hard conversations to have because our leading conversation is, if you have that information, what are you going to do with it? So that's sometimes a really hard, concept to grasp for family and the patient. So we just kind of help with that.
What kind of resources do you have at your fingertips that you can recommend to your patients?
Well, a big resource that I utilize is Direction Home. It's an area of aging, and it's a resource that helps connect elder individuals and people with disabilities to different resources in the community. So if we have individuals in the home that might benefit from private caregiving duties, but financially they can't afford, to pay for that. So sometimes they can qualify for in-home services through Passport, or maybe they need, assistance getting connected to Medicaid, or, so we work a lot with Jobs and Family Services as well, in the VA as well. So.
Oh, I wondered about the VA, if you get connected with them for any of your patients. Do you ever have families that are social worker resistant?
Yeah, we do, and that's okay. I think it's such a big decision to come onto hospice. Sometimes people don't want to talk about it a lot, or some people are more private with how they process their emotions, and that's fine. That's totally okay. So we're in the background a lot. So if they decline services up front, we'll still call and check in monthly just to make sure things are okay. And maybe they change their mind. Maybe they would like to talk about some things, and they're ready for that discussion. So
I think that people are going to accept the help that's given to them in very different stages or very different ways. And again, with my mother, we worked wonderfully with the whole hospice team. When my father was a hospice patient, he wanted absolutely nothing to do with any service other than that of nursing. That was it.
Yep.
And we had to accept that. The nurse had to accept that, and my sister and I had to accept that. So that it's hard to overcome that, isn't it?
Well, yes, because sometimes I think the family would benefit from additional support.
I completely agree.
Especially when we have our patients in the home, their primary caregivers, they can experience caregiver burnout, and emotionally they're saying goodbye in stages to their loved one as they're seeing different stages of the disease take place. So it's a lot to wrap your head around. So what's great about our services is that we tailor it not only for our patients but our family members as well. And sometimes my services are more so for the family and not the patient.
And not the patient.
Yeah. So.
Laura, do you go into other settings besides the home? Do you go to, I guess it wouldn't be hospitals, do you go into nursing homes or assisted living, that kind of thing?
We do. We are able to go, and we do have lots of patients that are in long-term care settings. So assisted living or a skilled nursing facility. So we're able to provide our services that way. So.
And so it wouldn't be resource-based, I would assume, then. It would be more social, support?
Yeah, so if someone's already in a facility, that means that they're already receiving nursing care and aid care. But so our services are in addition to what they're already receiving. So they would still have a hospice nurse come see them, and they would still have aides come and provide personal care in addition to what they're already getting. So it's a great asset to their
I didn't know
care
that.
plan.
And then you as well coming in. So the team still stays with the patient regardless of the setting.
Right.
Oh, that's wonderful to know. I never knew that. Let's put on the bereavement hat.
Sure.
And grieving, my gosh, everybody grieves so very differently. And nobody wants to talk about the end of life. I don't know, well, maybe some people do, but it seems in my experience that people just keep wanting to think it's not going to happen to all of us.
Sure.
How do you overcome some of that, the barriers to discussing and grieving and all of that stuff?
Well, I think what's helpful for my role is that usually I'm meeting our family members at the beginning of services as the social worker. And so my goal is to build that rapport and have a trusting relationship and get to know them and their life experiences. And through that, I kind of get to know their styles of how they process emotions. So then I know how to approach certain topics of conversation. Maybe some people are more private, so you kind of have to take a while to approach that type of a subject. Or some people are more open, where you could just be more direct. So,
Are you there then with the family after the loved one has passed?
yes, so with bereavement, Medicare, they offer bereavement services up to 13 months after your loved one passes. So grief support. So that's through educational mailings, through phone calls. We have memorial services for our patients.
Really?
So just even in-person visits, just going to a coffee shop or their home, wherever they feel comfortable, and just providing a platform that they can process those feelings.
Because people don't want to necessarily talk about those feelings with friends because they think it's going to be boring them, or
Sure.
they, it's the same old, and
Well, yeah, I think we all get that initial wave of support the first couple
Right.
weeks, and then, our culture is kind of pick yourself up by the bootstraps and
Isn't
keep
it, though?
going. Right, and so sometimes I think people feel uncomfortable to bring that topic up when people stop asking. So what's beneficial about the bereavement program that hospice offers is that we give them that opportunity to talk and just see where they're at with their grief journey.
do you ever have a need to help with or to seek help for additional resources? I'm thinking, essentially what you're doing is therapy, but do you ever think, gosh, this person is really in the depths of depression and
Sure.
needs more help than I can give?
Oh, absolutely. So when that happens, I help them with their financial situation, what they can afford or what they feel comfortable with, connect them to either individual therapy or group therapy, specializing in grief. So, and then that way they can receive a more tailored, specialized interventions appropriate to what they're going through. And then I would still work with that person and just kind of help enhance their treatment goals. So whatever they're working on with their therapist, just kind of act as a reinforcer.
Do you see any people, how long do you see, so it's 13 months?
So 13
That's-
months, but that, we have had cases where we continue to follow family members, and
Do
sometimes...
you really? Past the 13 months?
It's kind of more informal, but we're not sticklers to that 13-month. And then some family members, after a couple months, they feel they don't need our services anymore. They feel comfortable without that support, and that's okay too. And sometimes we have people that decline our services initially, the bereavement support, and then a couple months later they might call and say, hey, I was wrong, I'm starting to feel some different emotions that I wasn't anticipating. So it's not, it's very flexible type of program, and it's tailored to their needs. So,
Laura, everything I've heard about your hospice program, it has been so impressive to me because it really does appear to be, from beginning to end, very, very patient-oriented and very supportive of the patient and family. Unlike, there aren't always hospice, they don't always, aren't like that.
yeah. That's definitely, I think that's part of our mission statement, and it's
Yeah.
definitely something that we strive for, is to provide that tailored, person-centered care. And so it's a great asset for our team as nurses and chaplains and social workers and aides to try to tailor that plan for that individual and family. And it's another enhancement is we also offer home care, and so private duty caregiving. So
That's right.
right.
So you could just they could be one of your resources.
Right. So it's really, and that's a great asset to our team as well, because sometimes they might start off with that part of our company with the caregiving, and then they might become hospice appropriate. So then it's a continuity of care.
Yeah.
Or we have home patients that might benefit from caregiving, and of course we present them with options, but it just makes sense to kind of go with our home care then.
Sure.
So it's under one umbrella, and the
Yeah.
communication, everything's under one.
Oh, I think I really was impressed with that when I heard about it
Yeah.
earlier this year. Do you ever see clients who are not part of that umbrella, who were not originally with either home care or hospice, just as a I don't want to say a therapist, but as a counselor for bereavement? Does that make sense?
Yes, it does. So with our bereavement program, we can offer grief support to anybody in the community, whether it's education or assessing what their needs are, and either ongoing, keeping in contact, or referring them to, a more specialized approach. So
Has that happened with you? Have
It
you
has.
had that?
We've had phone calls that, would come in and they say, we didn't have services with your hospice, but we're just having a really hard time right now. And so we just kind of do an initial assessment and see what they're going through, and figuring out what their needs are, and not just assuming, so.
Let's see. Non-clients, all right, we covered that. Therapist, if you need them, you know where to get them. I mean, I'm thinking psychiatry, or, people if they need antidepressants or whatever. What is the best part of your job?
Well, I think the best part is really just being there for our patients and our family members when they need it the most, and making them feel empowered to go through this part of their journey that can be very scary and emotional. So the fact that we can come in and help that transition, I don't want to say easier, but maybe more comfortable or bearable or manageable, I think that's the best part.
I think that, having gone through it twice now, I think as an older caregiver to my sister and I, are both around the same age to my father, we wished we had had more support as caregivers. And I think that that's something that I wish the hospice program had offered to provide. It was very centered on the patient and his medical needs. And I think that caregivers need support too.
Absolutely. I think it goes unnoticed sometimes, the amount of work that you put in on a daily basis. And
Exactly.
when your loved one is declining, their needs increase, and that means you're getting pulled in a lot of different directions. And sometimes that caregiver is not only adjusting now to caring more for their loved one, but maybe they have to take on other responsibilities of the household.
You got it.
Like paying bills,
You got it.
lawn care. Oh no, a pipe's leaking. So you have
got
to be
it.
a problem solver.
Leak in the basement.
Right.
You got it.
So
That is exactly our scenario. But my dad died peacefully, and is now with my mother. So I'm sure they're probably having lunch right now together.
absolutely.
Laura, thank you so much for coming. I truly appreciate this. I've wanted to hear about your services for some time, and I have to say that your boss has just been talked about you with such wonderful words. I mean, he really thinks that you are just doing a wonderful job. I'm sure you know that, but I was looking forward to meeting you in part because of his glowing recommendation.
Oh.
So thank you for coming.
I appreciate it. Thanks for having me. So.
This is North of 60. Thank you for watching.